Welcome back to part two of the pulmonary lecture, Restrictive Lung Dysfunction by Professor Steve Johnson. On behalf of Professor Johnson and Professor Kittleson as part of the cardiopulmonary program. We're going to resume where we left off at the pulmonary pathologies. Again, we were talking about different causes for restrictive lung dysfunction. We had finished off on some developmental maturational causes, and we're now going to discuss pulmonary causes of restrictive lung dysfunction. I have arranged the various pathologies a little bit differently than they are listed in your textbook. The reason for this is that I wanted to list the ones that I think you will encounter most often in clinical practice rather than just how they were listed in the textbook. The first pulmonary cause of restrictive lung dysfunction that I want to discuss is pneumonia. Pneumonia is categorized in several different ways. The first being whether it was acquired in the community or whether it was acquired in the hospital. A hospital-acquired pneumonia is referred to as nosocomial infection or nosocomial pneumonia. That is further broken down into what's referred to by its acronym a HAP, an HCAP, or a VAP. And those have different meanings in terms of, was it hospital-acquired pneumonia, which would be a HAP, an HCAP, which would be a healthcare-associated pneumonia, or VAP, a ventilator-associated pneumonia. The community-acquired pneumonias are divided into two categories: an acute onset of pneumonia or a chronic pneumonia in an individual with other pulmonary dysfunction that makes them susceptible to ongoing infections. Pneumonia is a very troubling illness and one that causes lots of death and debility. The World Health Organization reports that there are 3.5 million deaths annually worldwide attributed to lower respiratory tract infections. This makes it the number 3 cause of death and the number 1 infectious cause of death worldwide. And just alone in the United States, there are 50,000 deaths annually attributed to pneumonia. That makes it the 9th leading cause of death in the U.S. So again, pneumonia is a serious condition. I think one that in our modern healthcare mindset with antibiotics, etc., we don't think of pneumonia as the great threat that it really represents. When it comes to community-acquired pneumonias, the villain, as we shall call it, is Streptococcus, which is sometimes also known as pneumococcus. The Streptococcus pneumonia, is shortened to pneumococcus, is the most common community-acquired pneumonia, and estimates range anywhere from 20 to 70% of all pneumonias have a component of Streptococcus involvement. Other causations for community-acquired pneumonia can be other bacteria, viruses, or even in some cases fungal infections. Fungal infections causing pneumonia are extremely rare and typically only seen in individuals with immune compromise or extremely frail individuals. Funguses are much more opportunistic, and so typically people with a healthy immune system are able to prevent fungal type of pneumonias. One of the things related to community-acquired pneumonias is that in recent years, the antibiotic-resistant superbugs, which do not respond to typical antibiotic treatments, have created difficulties with curing or healing people who develop these pneumonias. Some examples would be MRSA and C. diff. Going back, the number one culprit or villain when it comes to nosocomial infections is the Pseudomonas aeruginosa, which is responsible for 15% of all hospital-acquired pneumonias and 40% of all ventilator-associated pneumonias. So Pseudomonas in the nosocomial environment and Streptococcus in the community-acquired environment are the two bacteria most commonly associated with these types of pneumonia. We'll now talk about some other pulmonary uh, pulmonary associated restrictive lung dysfunction actors, bronchogenic cancer, pleural effusion, idiopathic pulmonary fibrosis, coal workers, pneumoconiosis, silicosis, and asbestosis, bronchopulmonary dysplasia, bronchiolitis obliterans, atelectasis, acute respiratory distress syndrome, which is formerly known as adult respiratory distress syndrome, and sarcoidosis. We'll talk about each of these again here individually, but I just wanted to list them out for you. Again, there's no expectation that you would memorize this laundry list of pathologies, and this isn't a patho course. However, I do want to discuss each of these in a little more detail to explain the acting mechanism as to why these various pathologies then result in restrictive lung dysfunction. So talking about bronchogenic cancer, bronchogenic cancer is divided into small cell carcinoma and non-small cell carcinoma. There are 4 distinct types of cancer. 3 of them are referred to as non-small cell, and then obviously small cell. 85% of all cancers, lung cancers, are non-small cell cancers. They are referred to as squamous cell, adenocarcinoma, and large cell. 15% roughly are small cell cancer. Sadly, 80 to 90% of lung cancers are just moving forward to find the slide here to talk about cancer issues. 80 to 90% of lung cancers are directly related to tobacco use. If an individual starts smoking before the age of 15 and they have a 50-plus year smoking history, that individual is 100 times more likely to develop lung cancer. The prognosis for people diagnosed with lung cancer is very poor. There is a 41% mortality rate within the first year of diagnosis. So 4 out of 10 people diagnosed with lung cancer will be dead within 1 year. What you will see when you go out into the clinic and you're working with patients is a international cancer staging system which looks at what's referred to as the T as in Tom, N as in Nancy, M as in Mark, TNM staging system, which stands for tumor, nodal involvement, and metastatic extent. And so we're not going to go through, again, this is not a pathology course, so we're not going to go through the staging system and expect you to be able to identify various stages, etc. What I want you to understand is that you may see somebody with a score, a TNM score, which is going to refer to what's the status of the tumor, how much nodal involvement is there, and are there other metastatic where the cancer has moved from the lungs to other places. Adenocarcinoma is the most common of all lung cancers in the US and is responsible for 40 to 50% of the cases of lung cancer. What is the restrictive aspect of lung cancer in terms of restrictive lung dysfunction? Obviously, the growth of a tumor becomes a space-occupying lesion, which results in a loss of space for actual lung and tissue function. Secondly, the tissue is being replaced, so the normal tissue that would normally be devoted to air exchange and to breathing now becomes non-functioning tumor tissue, as well as a loss of typical flexibility and compliance with the tumor. Here's a patho slide. I'll try to move the slide a little more gently, not having much success with that. There we go. So again, a normal slide of healthy lung tissue. As you look at it, you see lots of open air. It looks like kind of, if you've ever seen a cross section of a sponge, lots of open cell space. That is the open air sacs, critical for air exchange. Obviously, you now see a pathological slide cross section of an area of lung that's been invaded by lung cancer. And you see a loss of that airspace being taken up by the tumor and lack of functionality for the tissue. The next topic we're going to talk about is pleural effusion. The lungs, obviously similar to the heart, have a protective sac that goes around, that pleura goes around the lungs and is kind of an oily, fluidy substance to basically prevent friction and irritation of the tissues with the expansion and contraction of the lungs with normal breathing. That amount of pleural fluid under typical situations would be roughly 10 to 25 milliliters. So a very, very small, you can kind of picture it as sort of a oil grease kind of between bearings, a very small amount just to keep that lung tissue from sticking or rubbing against the chest wall. This fluid is constantly being exchanged by the pressure gradient difference between the parietal and the visceral barriers. And so the parietal being higher pressure, the visceral being lower pressure, there'll always be fluid moving through this space due to hydrostatic pressure. Something that we will talk about at length during the edema management lectures about hydrostatic pressure and its cause of filtration through tissue barriers. So normally there's fluid moving through the membrane, constantly being cycled through, but that amount again is typically 10 to 25 milliliters. And what happens is in an unhealthy situation, such as with congestive heart failure, there's an accumulation of fluid in the pleural space, and you end up with a transudative fluid buildup. Or it can be inflammatory in nature, which is referred to as an exudative buildup, where you have high protein leakage as a result of a pulmonary embolus, a neoplasm, or disease states such as tuberculosis. In those pathological states, the fluid buildup in this pleural space can reach as high as 3 liters of fluid. Obviously, the amount of fluid that starts to build up, and this diagram shows the example, that fluid starts to build up and the lung itself doesn't have room, and so the lung becomes compressed due to the fluid built up, and it prevents the lung from functioning. So you have a loss of compliance essentially, as well as just volume. And so typically, again, and this is where they can go in, they can insert a needle into the chest wall, and they can take this fluid off of a patient. And again, in acute care settings, this is something you will see from time to time. Okay, we're going to back up a couple slides. Back to the reference slide listing all of the different pulmonary causes of restrictive lung dysfunction. And we're going to talk about idiopathic pulmonary fibrosis. Idiopathic pulmonary fibrosis, as the name indicates, is a poorly understood process where otherwise healthy adults begin to develop fibrosing in their lung tissue and end up with loss of pulmonary function as a result. Some of the new research that is in your latest edition of Hillegas is indicating that there's been a link to some sort of irritant being breathed into the lungs, and that irritant then the body reacts with excessive fibroblast activity as part of that reparative process. So there's some sort of an insult to the lung, breathing in some sort of irritant. The body's immune system reacts, begins to repair the tissue, and unfortunately in these individuals, there is an excessive amount of fibroblastic or scarring activity that occurs. Obviously, it results in damage to the alveolar wall, and that scarring will reduce the ability for the lungs to exchange air as well as the compliance of the tissue to move back and forth. Idiopathic pulmonary fibrosis is one of 4 typical conditions that put people on the list of being eligible for a lung transplant. The other conditions are cystic fibrosis, emphysema, and pulmonary hypertension. We're now going to discuss, kind of in concert with each other, coal workers, pneumoconiosis, silicosis, and asbestosis. I list these 3 together because I believe the mechanism is similar and they are essentially workplace-related pathologies that then result in restricted lung dysfunction. Coal workers' pneumoconiosis is seen in the coal industry, particularly in miners who spend excessive amount of time in confined spaces breathing in air that has coal dust particulates in it. Coal workers' pneumoconiosis is defined as either simple or complicated, and it's based on the length of exposure and often results in chronic bronchitis as a result of the condition. Essentially, how long somebody has spent mining coal, working in that environment, it results in them developing complicated CWP versus simple CWP. The medical definition listed in the book stated that less than 5% of cases progress to a complicated state. So 95% of people diagnosed with CWP will be diagnosed with simple CWP. Not to be brushed off, that the term simple simply meaning that it's a less severe state of the disease. It is still a disease state with complications and limited lung function. We're going to see some slides here in a minute looking at asbestosis and coal workers' pneumoconiosis. Another condition is silicosis, very similar mechanism, inhalation of silicon dioxide found in sanding and grinding occupations, as well as those who work in quarry environments. Breathe in rock dust, silicosis, silica, and end up with scarring in their lungs similar to the coal dust, similar to the asbestos. Asbestosis, again, fibrous silicates that were used extensively in the shipbuilding and automotive industries, as well as it was an excellent insulator and fire retardant, and so was stuck into most major industrial buildings as well as homes for years and years until it was discovered to cause such severe lung issues. And so uh, the asbestos fibers get into the lung tissue, similar to the coal dust and similar to the silica, and end up causing long-term lung dysfunction. So we'll take a look at a couple slides further into the presentation here. So again, you're looking at normal lung tissue as a reference, and you've got those nice alveolar spaces for air exchange, and you've got tissue surrounding that. You now have a cross-section slide of coal workers' pneumoconiosis, and obviously you can see the particulate, coal particulate tissue gets into the tissue area that the body then reacts to it and becomes inflamed, and then you see a change, a morphing of the healthy tissue, normally like a sponge, now becoming more solidified because the body has encapsulated and essentially created scarring around these particles that are trapped in the lungs. Here's a similar slide, again with your typical reference on the left, and your atypical with the asbestos fibers trapped in the tissue then becoming inflamed around it and essentially scarring around those fibers, and you don't see the ability for the body to then have that nice, good, adequate air exchange. All right. Going back to our list. Bronchopulmonary dysplasia, also known as ventilator lung, is a result of the positive airway pressure that when a person needs to be ventilated, similar to when we were talking about developmental maturational issues and hyaline membrane disease in infants. Similarly, the way that we normally breathe is a gentle process. When a ventilator has to force air into your lungs, these very, very fragile tissues, for those of you who have ever done any dissection work with lung tissue, it is a very, very light, almost puffy, fragile material, and to force air into the lungs in order to keep the patient alive with the necessity of a ventilator, those very fragile tissues end up with a negative reaction as a result. And so the amount of time that a person needs to be on a ventilator is directly related to there's a direct link with the development of this condition of the bronchopulmonary dysplasia, where you start to see actual tissue changes as a result of the stress of the positive air pressure forcing the air into the lungs, resulting in tissue change, loss of compliance, loss of air exchange ability because of those physiologic changes. Okay. Bronchiolitis obliterans is a fibrotic lung disease attacking the small airways and causing necrosis of the respiratory epithelium. There is now some thought that RSV infection in children may trigger, and other other infectious agents in adults, and or exposure to toxic fumes can also result in this. Again, you see in bronchiolitis obliterans, you see a destruction of lung tissue, resulting in a loss of compliance and loss of ability for the body to perfuse and exchange carbon dioxide and oxygen. Atelectasis is defined as an incomplete expansion or loss of volume as the result of a collapse, compression, or obstruction of the lung. Okay, so atelectasis is essentially where the lung is not able to expand due to either something preventing it from expanding or from some type of collapse of the lung due to a change in the internal pressure. Atelectasis is classified as one of 5 types. 1 is resorptive. 2 is a passive pneumothorax. 3 is adhesive. 4 is compressive. Think of a neoplasm. A tumor growing in the lung is going to compress that area of lung space. And 5 is, I'll probably murder the pronunciation, but cicatrization, which is a volume loss due to fibrosis. So those are the 5 kind of causative things that can result in an atelectasis. We have a slide a little bit further down in the presentation here, an MRI cross-section of lung tissue demonstrating a loss of lung volume as a result of atelectasis. And again, if you think about it, whatever the causation is for the atelectasis, the end result is the body no longer has the ability to use all of the lung space that it normally did. And so the severity, how much is the atelectasis going to be limiting to the patient, is going to be largely determined on how severe the atelectasis is. Acute respiratory distress syndrome, ARDS, as I had said earlier, was formerly known as adult respiratory distress syndrome, is now referred to as acute respiratory distress syndrome. It is a result of an acute lung injury causing alveolar separation and fluid infiltrate changes so that the compliance of the lung tissue changes. This can be the result of severe high altitudes, trauma to the lungs. Can also happen as a result of the patient having to be on a cardiopulmonary bypass unit for a surgery. Ultimately, acute respiratory distress syndrome is a change to the physiological compliance and the ability of the tissues to respond normally to allow for air exchange and functional breathing. Finally, sarcoidosis is the presence of epithelioid granulomas, and this can show up all over a person's body. And so again, this is not a pathology course, but just wanting to explain how a patient with sarcoidosis could have restrictive lung dysfunction if those granulomas appear in the lungs. Those granulomas are going to, like a tumor a neoplasm, they're going to be space occupying, and depending on where they are also going to affect the compliance of the tissues around them. That concludes the pulmonary causes of restrictive lung dysfunction. We're now going to talk about some cardiovascular causes of restrictive lung dysfunction. The first being pulmonary edema, which we discussed related to congestive heart failure and discussed in how that can then result in pleural effusion. And so obviously congestive heart failure can result in pulmonary edema, and the mechanisms we discussed during the cardiac portion of the course. So I will not review that here, but again, make sure you understand the mechanism of how fluid can build up in the lungs due to pressure changes when the heart is not functioning adequately to move blood through the circulatory system the way that we need it to. A second cardiovascular cause of restrictive lung dysfunction is a pulmonary embolus. And again, we discussed pulmonary embolisms extensively during the cardiac portion of the course, but just wanting to review here that sometimes treatment options are the placement of a greenfield filter or an IVC filter to catch those blood clots, leaving typically the lower extremity and traveling to the lung, and the use of heparin and Coumadin to prevent those clots from getting big enough to cause significant areas of death or destruction. So again, we have a picture here of a IVC filter, and also just a artist's rendering of what happens when that blood clot is released. It travels up the vena cava, gets into the right atrium, into the right ventricle. It is then travels up to the lungs. And again, these are all large areas where that big hunk of clot can move freely. And then it starts to get into the narrowing of the blood vessels in the lung until it reaches a point where that clot can't go any further. And when it reaches that point, wherever that is, everything from there downstream will no longer have blood supply. And so again, depending on the size of that clot is going to determine how much of the lung is affected. And if too much of the lung is affected, as I believe we talked about in the course, 1/3 of patients that have a pulmonary embolus will expire within 1 hour of onset of symptoms. And so 1/3 of these clots are big enough that they block off enough of the lung supply that this condition becomes fatal. The estimates are that as many as 600,000 pulmonary emboluses occur each year in the US. The reason that they're not sure and they have to estimate is that up to 20% of these pulmonary emboluses may be small enough that they are silent. They are never noted medically. The other estimate is that up to 100,000 deaths per year could be the result of pulmonary embolus. Interestingly, orthopedic patients with lower extremity surgical procedures are at the highest risk, and there is an estimate that up to 80% of postoperative hip and knee patients will develop DVTs. To me, that was an astounding statistic, and one that I had not heard before beginning to become an instructor in this course in the last 5 years. I had never realized that there was that high of an incidence of postoperative DVT formation. The other statistic that the book relays is that 95% of all DVTs, all pulmonary emboluses, are the result of lower extremity DVTs. So those DVTs in the lower extremity cause 95% of pulmonary embolus episodes. Okay. There are also neuromuscular causes of restrictive lung dysfunction. The most significant being spinal cord injury. Depending on the level of the spinal cord injury, you're going to see a loss of typical muscles used for breathing, and you will see a loss of chest wall control. That loss of chest wall control can lead to what is described as paradoxical breathing. We're going to watch a short video clip in class on Tuesday demonstrating what paradoxical breathing looks like. It is where the diaphragm is still functioning, but the diaphragm actually will descend on inspiration and the abdomen pushes out, but what happens is that the rib cage and the thorax no longer has the bucket handle and the pump handle mechanism to expand, and so as the diaphragm is pulling down, you will actually see a pulling down of the chest wall rather than an expansion of the chest wall. And this is what's referred to as paradoxical breathing. And like I said, we'll watch a video of this. Certainly you can YouTube paradoxical breathing and look at that yourself prior to class, but we'll pull up some video examples in class and take a look at paradoxical breathing. Again, the severity of the spinal cord injury is going to determine the amount of involvement of the lungs. Obviously, somebody with a lower thoracic spinal cord injury is likely not going to be suffering any restrictive lung dysfunction, other than if there's some postural issues. Other neurologic conditions include amyotrophic lateral sclerosis, or ALS, a progressive degenerative neuromuscular disease of the upper and lower motor neurons. This is also known as Lou Gehrig's disease. And again, typically death results when paralysis reaches the point that the person can no longer breathe functionally, and so loss of the ability to control the muscles of inspiration and expiration. Poliomyelitis is not heard of as much anymore with the eradication of polio in the United States and largely in the world. Post-polio syndrome, you still may encounter this with some of your elderly patients who had polio prior to the Salk vaccine. And again, the severity of how bad the demyelination and the polio condition will determine how much respiratory limitation there is to the patient. Some other conditions, Guillain-Barré, again, a demyelinating disease that's very poorly understood. 10 to 20% of patients suffering Guillain-Barré will develop acute respiratory failure and require ventilation. Again, going back to the pulmonary causes, respiratory failure, patient having to be ventilated, the ventilation is going to have some effect if it's prolonged. The good thing is, for most of these folks that develop Guillain-Barré, they make a full recovery. The length of time to make that recovery it varies from individual to individual. I will tell you about a particular individual that I saw this fall uh, suffering from Guillain-Barré, and kind of an interesting story. Myasthenia gravis is a chronic neuromuscular disease with progressive muscle weakness on exertion, and roughly 10% of these patients will develop effect that affects their respiratory muscles. Tetanus, why is it every time you step on a rusty nail or cut yourself, they're always giving you a tetanus shot? the neurotoxin Clostridium tetani uh, causes tonic convulsions, and obviously, if you have tonicity and tonic convulsions, your ability to expand your chest wall to breathe becomes limited, and so not wanting people to develop uh, that sort of condition. Whenever somebody has a cut or steps on a rusty nail, you will be getting a tetanus shot when you go to the doctor. Pseudohypertrophic muscular dystrophy, also known as Duchenne muscular dystrophy, is a genetic progressive degenerative myopathy. Eventually affects respiration and is the cause of death in 75% of patients with muscular dystrophy, and this can happen typically around age 20. So again, a very shortened lifespan for children with Duchenne's muscular dystrophy, and the eventual cause of death is typically the inability to respirate. Okay, again, I had talked about the fact that we want to take a look at paradoxical breathing. We'll do that in class. We're now going to move on and talk about some musculoskeletal causes of restrictive lung dysfunction. The first topic area is going to be diaphragmatic paralysis or paresis. In cases we discussed earlier, bronchogenic cancer, there's a causation where the cancer actually will, if the cancer is in the area of the phrenic nerve, there can be damage to the phrenic nerve, which will then cause partial or complete paralysis of the diaphragm. Interestingly, 20% of all patients undergoing cardiac surgery will end up with phrenic nerve injury, where the phrenic nerve is nicked or severed. And as a result, during inspiration, the diaphragm will be pulled upward and the ribs will be pulled inward rather than expanding. And this will become more pronounced when the patient is in supine, if you see someone with diaphragmatic paralysis. Kyphoscoliosis. Again, we're going to hopefully have Dr. Morchin in this fall to give a very good lecture on infant and child development, and how the development of our chest wall is critical to our ability to respirate and exchange air. In those cases where people have significant kyphoscoliosis, I'm going to show you a slide here. We always look at this from a musculoskeletal standpoint and look at what are all of the things that are being impaired in terms of upper extremity functionality, gait, posture, ability to do things. I think one of the great disservices that we as PTs do is that we don't think about what sort of limited cardiopulmonary capacity does this individual have as a result of their severe scoliosis or kyphosis, and how do we account for that when we look at plans of care and intervention with patients like this. And again, Dr. Morchin will go into this in more depth and talk about how sometimes some of the things that we come up with to improve positioning may actually impair ventilation. Two other conditions, pectus excavatum or funnel chest is a condition where the sternum and the thorax is malformed, resulting in a deformity to the chest. This can be clinically insignificant, other than obviously visually striking. The individual still may function normally and be able to ventilate adequately to do all the activities that they wish to do. Again, it will depend on the severity of the excavatum. The other condition, known as pigeon chest or pectus carinatum, is kind of a reverse, where the chest wall forms much more similarly to that of the thorax of a bird, where you end up with the sternum being much more elevated and pronounced. Again, other than being visually striking, this may not affect respiration, entirely dependent on the severity of the condition. The other condition that we did not mention, I do not have a slide for it, is ankylosing spondylitis, which is also known as bamboo spine. And that is a progressive condition of inflammation and resulting inflammatory response, which results in fusion of the spine and a loss of movement of the spine, which again, when you think about the ability of the chest wall to expand, the ankylosing spondylitis can have a limiting factor and result in some decreased lung volumes as a result of this restriction. I'm going to go through some additional causes of restrictive lung dysfunction. We will go through these rather rapidly. Again, they're noted in your text, and I mainly bring these to your attention so that as you're treating patients in the clinic, as you go out on your careers, you don't forget about the cardiovascular implications with patients that you may be seeing for an entirely different reason. You may be seeing them because of their neurological condition. You may be seeing them because of their rheumatoid arthritis. But again, I think there's a great disservice done when we don't think about the ability of the patient to ventilate and the amount of work that somebody can do. You can have them exercise and get really strong leg muscles, but if they don't have the ventilatory capacity, you really haven't helped them a whole lot. So, some connective tissue causes of restrictive lung dysfunction include rheumatoid arthritis. The estimates of rheumatoid arthritic patients who end up with restrictive lung dysfunction is highly varied. Anywhere from 5 to 58% of these patients will experience pulmonary involvement and fibrosis, causing complications both with chest wall expansion as well as soft tissue. Systemic lupus is an autoimmune disorder, and anywhere from 50 to 90% of patients with this condition will have pulmonary impairment and diaphragmatic weakness. Some other conditions include scleroderma, polymyositis, and dermatomyositis. Scleroderma is a condition where collagen replaces normal connective tissues of the lung and results in fibrosing of the tissues, which obviously restricts compliance, which restricts ventilation. Polymyositis is a systemic connective tissue issue with symmetric proximal muscle weakness and can affect respiratory muscles, and in some cases, fibrosis in the lungs. These patients also are at a higher likelihood to have aspiration issues, and those aspiration issues can then result in pneumonia, which is also, as we discussed earlier, another causation for restrictive lung dysfunction. Dermatomyositis is another condition, and the symptoms, the pulmonary symptoms, are essentially the same as those that we would see with polymyositis. There are immunological causes for restrictive lung dysfunction, Goodpasture's syndrome and Wegener's granulomatosis. Uh, the Goodpasture syndrome, you will see intraalveolar hemorrhaging, and obviously the inflammatory response of that interalveolar hemorrhaging will result in restriction of the lungs. The granulomatosis is a vasculitis of the respiratory tract, and it results in ulcerations and, again, fibrous scarring. The body doesn't know, that this is going to result in decreased ventilation. The body just knows that it needs to scar and fix those areas where there's been hemorrhaging. But the end result is a loss of compliance and a loss of ventilatory capability. There are certainly gestational causes for restrictive lung dysfunction. As the fetus gets larger, it is going to be taking up more space and pushing up against the diaphragm, and the diaphragm being pushed up against the lung tissue. Obviously, the amount of restriction will be dictated by the position of the baby and how large the baby is getting. What's interesting is that the body counteracts this with the increased release of progesterone, which, among its many other uses, the increased progesterone actually does increase the ventilatory drive of the expectant mother. So nature has found a way to help with the restrictive lung dysfunction that's temporarily caused by pregnancy. There are nutritional metabolic causes for restrictive lung dysfunction. Obviously, obesity can result in hypoventilation due to that higher positioning of the diaphragm, due to the increased adipose tissue in the abdomen, and obviously can result in hypoxemia in severe cases. Diabetes is also listed as a potential causative factor in restrictive lung dysfunction due to the higher incidence of infections and the higher incidence of cardiovascular problems seen in patients with diabetes. There are traumatic causes for restrictive lung dysfunction. Just as some descriptions, there are crush injuries, penetrating wounds, pulmonary lacerations, and one that's not quite thought of quite as often is thermal injuries. A person is caught in a home fire, and the temperatures become so high that the air that they breathe into their lungs actually causes scarring and burning and scarring of the lung tissue itself. There are therapeutic causes for restrictive lung dysfunction. If a surgeon has to go in and remove a section of your lung, you will now have restricted volumes because that section or all of that lung is now gone. There's also post-transplant issues related to lung transplants and long-term results of either immunosuppressant drugs or the rejection by the body of that implanted lung. There's also, I would lump it under therapeutic, they list it as a radiologic cause of restrictive lung dysfunction. Patients that require some sort of radiation treatments, that radiation can do damage to the lungs. And again, as Professor Kittleson talked about, years ago, radiation treatments were much more scattered or global, and if a person had a breast cancer or some type of cancer in the upper chest wall, that radiation, I personally have seen patients that underwent radiation treatments in the 1970s, and a lot of those patients had scarring and burning that extended up into their scalenes and their sternocleidomastoid, and had permanent loss of tissue function in those areas because of cancer radiation treatments. Now they're much more pinpoint specific with their radiation blasts, but this certainly can be a causative agent, radiologic, which I would lump under therapeutic if it's being done for some type of medical procedure. Pharmaceutical causes of restrictive lung dysfunction, some of the anesthetics that are used, muscle relaxants, obviously if those things change the ability to ventilate, they're going to restrict the volume of air exchanged. So we talked about some of the causes. A pneumothorax can be caused by a puncture injury. When we were listing some of the traumatic causes, a penetrating wound, a stab wound, some type of sharp object, person falling on a sharp stick or something that punctures their chest wall. That change in pressure is then going to result in a pneumothorax and a collapsing of the lung. And so just wanting to show you sort of the artist's rendering of that pneumothorax, as well as a radiographic example of where you can see where that lung has collapsed as a result of the pneumothorax. I'm going to stop the lecture at this point and plan to, in classroom, I'm going to hit the high points of the audio lecture that I already covered and go through with you answering questions that you may have of some of the material that I've covered. And then what I'd like to do is spend most of the classroom time then starting to talk about what are some of the physical therapy interventions and giving you some patient examples that we can start to look at. Okay, if you had this patient with this condition, what would we be doing with them? Thank you. This concludes part 2 of the restrictive lung dysfunction lecture.